Good evening. My name is Todd Leininger. I am a physician in Bloomfield and Clarkston, Michigan, where I've been practicing spinal cord stimulation and other therapies for chronic pain patients for the last 30 years. I practice in a multidisciplinary group with psychologists, physical medicine rehab doctors, as well as pain specialists and neurosurgeons treating all different types of chronic pain. And this evening, I'd like to focus on the treatment of spinal cord stimulation using a new form of spinal cord stimulation called HFX, or high frequency stimulation. I have no disclosures. So really, what is spinal cord stimulation? The spinal cord stimulation is a non-pharmacologic therapy that works by delivering a very small electrical impulse to the pathways of pain in the spinal cord, effectively turning off or altering the pain signals as they transmit up to the brain. We think at this point that the primary mechanism of action is through increasing the effect of GABA, which is a inhibitory neurotransmitter on the spinal cord, but also it affects the brain. Conventional spinal cord stimulation using lower frequency stimulation has been around since the late 60s, early 70s, and has been used primarily to treat leg pain, though over the last few years, other forms of spinal cord stimulation, such as HF10, are now used to treat low back pain as well. And really what I'm talking about this evening is a new form of spinal cord stimulation using a different frequency. So traditionally, spinal cord stimulation is performed using or delivering low frequencies of electrical therapy, where it creates a paresthesia that essentially covers or attempts to mask the area of pain. So if you have pain in your feet, we implant the device such that it stimulates the feet and you get a sensation that is hopefully less painful than the pain that you already have. Using this new form of spinal cord stimulation, or HFX, we actually are delivering a subthreshold form of therapy that the patient does not feel, and it basically just decreases their pain. Spinal cord stimulation is minimally invasive. I'll discuss the trial and implant process a little bit later, and it is a reversible therapy as well. So there's no long-term tissue destruction or anything that is irreversible. So what I'd really like to present to you this evening is the data that is derived from two studies that have been published. The 6-month study was published in JAMA Neurology, and then the 12-month data was published in Diabetes Care. So again, I'm going to go through those studies as we proceed through the lecture this evening. In these studies, high-frequency therapy was used to, again, treat specifically diabetic peripheral neuropathy in patients that were refractory to conservative or traditional therapies. The traditional therapies in this point were really the gabapentinoids, as well as maximizing glucose control and antidepressants. The hemoglobin A1Cs all had to be less than 10%, and BMIs were less than 45, and it was done at 18 centers throughout the United States, with 216 patients initially entering in the study. There was also an option for a crossover at 6 months, and the patients were followed for not only pain but quality of life, and very interestingly in this study, neurologic function, which was really never looked at or certainly never improved in previous studies with spinal cord stimulation. This slide shows the baseline characteristics of both groups, both the traditionally treated medication managed patients as well as the high frequency patients. You can see that both groups are essentially the same. A couple of things to point out is the duration of pain was quite long, over 5 years in both groups of patients, and a significant number of the patients had what we would consider to be moderate to very severe pain scores with VAS is over 7.5. Their hemoglobin A1C levels, as noted, were also below 8 in the majority of the cases, and they were the BMIs were in the low obesity range. Here's the flow of patients in the study. 216 patients were randomized to the conventional medical management group or the spinal cord stimulator group. You can see that patients that did not have a successful trial left the study at 3 months. You can see there were 96 patients left in the medical management group and 88 patients in the stimulator arm. A couple interesting points on this slide is we call it the trial to perm ratio or implant ratio. You can see of 104 patients that went through a spinal cord stimulation trial, 90 of them actually got implanted, so just under 90%. And of the patients that were in the conventional medical management, the 96 patients, actually 77, so over 3/4 of them actually went on to go through to a spinal cord stimulation trial. And the same type of statistics apply here, where 64 of the 77 patients were implanted, which is a very high trial to implant ratio. Typically with things like post-traumatic pain syndromes and lumbar post-laminectomy or other spine diseases, spinal cord stimulation trial to perm ratio is probably closer to the 75 or 80% rate. So actually in this subgroup of patients, specifically with diabetic peripheral neuropathies, the implant ratio was quite a bit higher. Again, this just briefly looks at the crossover of the two groups. You can see that over 80% of the patients in the medically managed group did cross over, and none of the patients in the spinal cord stimulation group elected to cross over or met criteria for crossing over. This slide also demonstrates pretty clearly the effect of spinal cord stimulation with the two groups. So the blue line is the group of patients that went immediately to spinal cord stimulation. You can see they started from pain scores just over 7 down to 2.4, and then as they continued over for 12 months, their pain scores actually decreased down to 1.7. Then in the orange line group, we see the crossover group who had similar pain scores throughout the first 6 months, crossed over and immediately essentially got a parallel response to the effect of spinal cord stimulation, with their scores coming down right to the 2 range as well. A couple of interesting points with this slide and this data is really showing that the patients are getting long periods of pain relief, and you do not see a trend towards increasing pain over the 1-year period of time in the patients that we have year data here. And again, also the fact that it doesn't look like the duration of the pain is having a negative impact on the effect of spinal cord stimulation. This actually also is somewhat different than some of the other literature using spinal cord stimulation for other particular pain problems. There's some studies, for instance, looking at complex regional pain syndrome or reflex sympathetic dystrophy and using spinal cord stimulation, finding that after somewhere between 12 and 24 months, the likelihood of success drops dramatically. So again, it looks like the effect of spinal cord stimulation on the peripheral neuropathy patients is particularly profound. This slide is actually another way to try to demonstrate the relief that the patients had in their pain, and it looks at the same group of patients at 6 months and 12 months. And basically every horizontal line is a patient. And you can see that starting at the bottom left, that there are just a couple of patients who actually noted worsening of their pain in the 6-month group and one patient in the 12-month group. And then each of these, again, these horizontal lines as we move up this graph are the percent of pain relief for that particular patient at these particular points in time. And you can see if you use 50% pain relief, which is a traditional measurement of success with either medical management or interventional management, that the vast majority of the patients met this criteria, both at the 6-month and 12-month time interval. The next thing that this study brought to light that I think is particularly interesting, because this is something that we've never seen before in the patients with spinal cord stimulation, is the investigators looked at neurologic examinations over time, and they looked at lower limb motor strength, light touch sensation, reflexes at the patellar, Achilles, and the Babinski response, as well as a 10-point foot assessment using pinprick and a 10-gram monofilament. The investigators were then asked to compare the baseline neurologic examination to the neurologic examination over time, and what they found was that over 60% of the patients that were implanted had significant neurologic improvement. So I don't think at this point we really have a sense of why spinal cord stimulation is actually improving these neurologic functions. Traditionally, we think of spinal cord stimulation as working by inhibiting the excitatory pathways of the spinal cord, usually by a GABA-based response. So it's hard to, at this point with our understand why the patients would have neurologic improvement, but indeed a significant majority of the patients did have this improvement. So this is something very exciting that has been added to the literature here. This is another slide that depicts some of the neurologic dysfunction that is seen with diabetic peripheral neuropathy. So these images are basically at baseline on the left and then at 6 months on the right. And we're looking at 4 different types of dysthesias in this patient population: numbness, burning, tingling, and cold. So what you can see is that, again, just going to the left side of numbness, you can see that the vast majority of people had numbness in their toes and the bottom of their feet. And if you look at the 6-month data to the right, the next image to the right, you can see that most of the patients, or a significant number of them, had a decrease in numbness in this distribution. The burning pain in particularly responded very, very dramatically, where almost all of the burning pain was gone in the feet, as did the tingling sensation. And then the cold sensation improved as well. But you can see that the improvement in burning and tingling in particular, which are the things that patients typically are most distressed about, are dramatically improved in this patient population. And as we all know, the patients with chronic pain also have disturbance in their mood and sleep. These slides, this slide represents the changes that took place in the patients in these 2 categories. So you can see on the left, the sleep was dramatically improved, also pretty much paralleling the improvement in sleep. And again, you see that both in the initially implanted and subsequently the crossover group. And then on the right, significant improvement in mood, also again following essentially the response that they had with pain. So far we've demonstrated marked decrease in pain, marked decreased sensation of burning, as well as the other dysthesias, and then improvement in sleep and mood. And just to rule out that there was no other easy way to explain the pain relief, the hemoglobin A1Cs were looked at over time, and you can see that there was no significant improvement in hemoglobin A1C levels or glycemic control. So that did not have a significant contribution to the patient's pain relief. The patients were obviously also monitored for side effects. No patient had any type of neurologic deficit reported, and there were no explants for loss of efficacy. The most common significant side effect was infection in a total of 8 patients, or 5.2%. 3 resolved with conservative therapies, and 5 required device explant. This is consistent with other reports of infection for spinal cord stimulation, but also I think compared to, for instance, pacemaker implant, the infection rate is right around here, and it is even a little bit lower than things like total knee arthroplasty. So consistent with what we would expect for an implanted device. This patient profile or specific case study basically brings together all the points that I've tried to go over here this evening. This is a patient, 73-year-old male, BMI 32, has had a PDN diagnosis for 15 years, so obviously on the long side. Hemoglobin A1C is reasonably well controlled at 7.4. The patient has been on the gabapentinoids, Lyrica and gabapentin, for over 10 years, has tried NSAIDs and Tylenol. He has, in addition to type 2 diabetes, hypertension, hyperlipidemia, and a remote history of bladder cancer. The patient is noting a VAS score of 7, and is as well complaining of seizures of burning and numbness. And on his examination, he has widespread reduction in sensation of light touch and pinprick in a stocking distribution. His trial outcome, he had over 80% pain relief. He noticed a reduction in the pain but also his burning. His VAS score during trial was down to 1 from 7 out of 10. And 3 months post-implant, he had 85% pain reduction with a VAS score of less than 1 as well. He had no burning seizures at this point and noted some improvement in his numbness as well. This is probably a good time also just to really quickly go over the trial process, since I really haven't discussed that at all. So basically, during a spinal cord stimulation trial, the 2 leads are put in percutaneously into the epidural space. The wires come out through the skin, and the patient uses a controller about the size of a cell phone over the course of usually 1 week. During that 1 week, we monitor their pain scores. They go through different potential programming options, and then the leads are subsequently removed. And our expectation is that the patient reports a significant improvement in pain relief. We'd like to see at least 75% pain relief or so, and also some concordant improvement in functional capacity. So the patient is then scheduled for implantation of the permanent leads, usually anywhere from 1 to 2 weeks later, after those temporary leads have been removed. The implant process itself takes a little bit longer. The implant process is usually about a 45 to 60-minute procedure. The leads are placed back in. A small incision is made in the lumbar spine in the area where the leads enter. They usually enter around the L1, L2 area, with the tip of the leads in the epidural space up to T8, T9. And then the leads are tunneled under the skin into the flank, where about a 1.5 or 2 inch incision is made for the neural pulse generator. So the procedure is pretty straightforward. No tissue trauma to bones, ligaments, or muscles is taking place during the procedure. The patient's recovery from the procedure is quite quick usually. At this point, there are 2 companies that have a diagnosis-specific indication for implantation for spinal cord stimulation. Nevro got the HFX, or high-frequency stimulation, approval in the summer of last year, and then just the summer of 2021, and Medtronic just recently got an approval, actually in January of 2022. The Nevro study was quite a bit larger than the data that that Medtronic used to get the approval. And I just was going to kind of walk through these studies quickly. So the Medtronic had an RCT, 2 sites that was performed in 2014 and 15. They used low frequency spinal cord stimulation in both of their studies, both the 14, 15 and the 18 study. And again, the low frequency stimulation leads to a sensation or a paresthesia in the distribution of pain. So in the burning feet, for instance, you would implant the leads and manipulate the leads in such a way that the patients would have a sensation of a buzzing or tapping sensation in the distribution of their feet. They looked at these patients over 24 and 60 months respectively between the studies. There were 17 patients in the initial study, 40 in the secondary study, and their responder rates were significantly under 50%, both in daytime pain relief as well as nighttime pain relief, with an average pain relief of 46% in the first study and 34% in the second study. Again, this compared to an average pain relief of over 75% in the HFX or high frequency stimulation. That study did not look at, the Medtronic studies did not look at any reported neurologic improvements, whereas again, just under 70% of the patients in the HFX study had neurologic improvement, and as well, the number of patients was quite a bit larger, over double the number of patients. There are also significant driving restrictions with the Medtronic device, which is true with all the low frequency stimulation devices. The recommendation is that they are turned off during driving so that patients don't experience a sudden change in the sensation and lead to impairment of their ability to drive. The other thing that is very common with the low frequency stimulation patterns is changing patterns based on changing positions and changing activity levels. So sometimes patients will have to have a different program for things like sleep, walking, sitting, etc. And they can be at times frequently changing and interacting with their device throughout the day as they go through their day. With high frequency stimulation, again, it is a sub-threshold high frequency stimulation that the patient does not sense, so none of those things apply to that therapy. So just to wrap things up, the study met the primary endpoint that we were looking for. A significant, large proportion of the subjects benefited from the high frequency spinal cord stimulation, again, over 80%. The crossover patients did just as well as the initial spinal cord stimulator group. And again, I think an important point there is the duration of pain that the patients have is not a predictor of whether or not they're going to respond. The crossover data represents 6-month pre and post-implant data in the same group of patients. Clearly, based on the study, spinal cord stimulation using HFX is a safe and effective treatment for diabetic peripheral neuropathy, particularly with patients that have failed conservative medical management. The sensory improvements observed in many of the patients, again, 68% of the patients, I think is something completely new to the literature and something we've not seen with spinal cord stimulation before. There also is a very significant durability of effect. As the data has shown us, we have at least 12-month data, and now there's data as the studies go further showing prolonged data with this form of therapy. So with that, I'd like to close, and I'll be available for any questions that you might have. Thank you very much. I appreciate the opportunity to speak with you tonight.